Hello and welcome to OrthoNorCal educational webinar series. My name is Leah Rutinov and I will be the moderator for today's webinar. I'm honored to host this event together with Dr. Kenneth Mensch, upper extremity orthopedic surgeon, and Charlene Norquist, physical therapist at OrthoNorCal. Today's webinar topic is distal radius fractures and it's intended for patients' educations only. We will have Q&A session after the presentations, so be prepared to send your questions over to us using Q&A or chat buttons at the bottom of your Zoom screen. If you have any additional questions after the webinar, you can always email us at info@orthonorcal.com or call the office at 408-412-8100. The webinar will be recorded and recording will be available on our website within 24 hours. So go ahead and share that information with your friends and family. And with all that being said, I'd like to welcome our first presenter, Charlene. Welcome, Charlene.
Thank you. Thank you. Yeah, I'm happy to be doing this. So as she said, my name is Charlene Norquist. I am the physical therapy manager over at our Capitola office off of 41st and Jade. So today, Dr. Mensch and I are going to be discussing distal radial fractures. I will be talking mainly about the physical therapy side of things and how a patient generally presents to therapy and what we do to help them return back to normal function. So where I want to kind of start is, let me get to the next slide. My agenda for my portion of this slide is first I wanted to go over a little bit of just very briefly over the bony anatomy of the wrist and hand. And then a little bit into the kinematics of the wrist and how the wrist moves. And that's very important in us returning your function back to normal after these types of injuries. The second part I wanted to discuss is scar tissue, what it is, how it develops, and what we can do to kind of help you minimize the effects of the scar tissue so that your hand and wrist isn't stiff after the injury or surgery. And then finally, what physical therapy can do to improve your function after this injury. So to start out, this is just a general slide of the many bones that are in the wrist and the hand. As you can see, there are quite a few. Your wrist mobility really happens between the radial or the radius of the forearm primarily and what we call the proximal row of the carpal. So the scaphoid, the lunate primarily, and then some other little bones. There's also some motion that occurs between what we call the mid-carpal joints. So the proximal row of that carpal bones, as well as with the distal row. So the other bones like the hamate, the pisiform, the capitate, and the trapezoid. So those contribute also to the motion of the wrist. So when we look at the motion of the wrist, oops, hitting the wrong button. There we go. So this is a general slide of what flexion and extension of the wrist, what happens at those joints. So when we extend the wrist or bring it backwards towards like the back of our forearm, you will get a kind of a rolling or a kind of a rolling of the bones on the radius below. And then also you get a gliding of the bones so that, you know, I kind of attribute it to if we just rolled, it might roll off the edge of the bone. So our bodies have to glide it that way so that it kind of stays central to the radius. And then the opposite will occur when you come forward into wrist flexion. Most of that motion will occur between the radius and the proximal row of the carpi, but there is, as the slide demonstrates, there is some motion that also occurs between the two carpal rows. Similarly, when you radial or ulnar deviate your wrist, which is basically turning your wrist kind of side to side like this. So when you do that, you have also similar motion, but this time we're kind of rolling this way with a glide kind of coming opposite. And vice versa, when you ulnar deviate, you're going to roll the bones this way with a glide that comes this way. Okay, so you can see how it's imperative that, you know, after an injury, we restore these motions so that you get this full wrist range of motion that is important for daily function. The other part of wrist mobility is pronation and supination. So this motion primarily occurs in the forearm between the radius and the ulna. And what you have is a kind of a crossing. So when you pronate your wrist, your radius will cross over that ulna. And it does so by spinning at the proximal elbow joint. So that also is important to make sure that we address that after injury, because this is a super important motion as well, right? To be able to turn your wrist up and down. So those are other areas that the physical therapist will look at and address when you come into your sessions, if needed. And then the supination is the kind of the opposite as well. So you have that spinning that occurs up at the proximal joint, and then the rolling over of the distal joint. Okay, so that's the general kinematics of the joint. But what is primarily found in the wrist is what we call coupled motion. So we want to make sure that we restore that kind of motion. So coupled motion means that you're generally rarely in a true flexion extension kind of motion. You're going to combine it, right? So they call that the dart thrower's plane, and it's almost like you're throwing a dart. So wrist flexion is generally combined with ulnar deviation, and vice versa. Wrist extension is generally combined with radial deviation. So we want to make sure that, you know, when we are addressing the mobility of the wrist, that we also make sure that that coupled motion is restored as well. Okay. So now that you kind of have a brief idea of how it moves, I want to kind of just switch gears and discuss healing. And the reason I want to discuss this is because if you've had surgery particularly, but even if you haven't, your body will heal, right? It creates scar tissue, it creates its process to be able to heal the area that needs to be addressed. So with that, we need to understand how we can, you know, impact the healing process so that you minimize the effects of your motion and mobility. So in the first phase, we have this inflammatory phase, and that's usually right after surgery or right after injury, up to about 1 to 3 weeks following. And this is usually characterized by an increase in swelling. You have the lymph system doing its work to remove, you know, debris and extra fluid from the area to kind of create the initial phases of the healing. Okay, and once you get past that, it's what we call proliferation, right? Or scar tissue starts to get laid down, and that's from anywhere from 2 weeks to sometimes up to 2 months. Okay. And it happens when scar tissue, when it lays down, scar tissue lays down in a very chaotic array. I put pick up sticks on there because that's kind of how I envision it, right? It's not in a very straight line that we would like it to be so that it moves in the directions we need it to be. It's very chaotic. And it's in this phase and the following phase that physical therapists can really help to minimize that chaos and get that scar tissue to be molded, in a sense, into the directions that we need it to be. Okay. This is a great quote that I had heard somewhere, that the good thing about scar tissue or scars, that it sticks things together, but the bad thing about scars is that it sticks things together. So scar tissue is a great thing. We need it. We absolutely need it to heal. But if we get too much, it can make it a little bit harder and make it worse. So we can have stiffness into our joints, into our skin, into our muscle tissue, wherever that scar tissue is laid down. And then the final phase of healing is called the remodeling phase, and this can occur anywhere from 3 months to 12 months. It can be a long phase of recovery. And this is where most of your remodeling of that scar tissue will take place. And so what we will do in physical therapy through the proliferation and the remodeling phase is to make sure that that scar tissue is molded so that it can tolerate all the stresses that you need to place on it for whatever activities you have to do. Okay. So the reason I talk about these things is when you have a distal radial fracture, you're likely going to be immobilized at some point. And the length of that immobilization is dependent on probably many factors, whether you had surgery, whether you didn't have surgery, the severity of the fracture, and other aspects that I'm sure Dr. Mensch will probably cover in his portion of this presentation. But when you have immobilization for any amount of time, you can get a lot of soft tissue issues. So adhesions of your tendons because of that scar tissue, the joint capsule and all those little joints that surround all those little bones in the hand and the wrist can get stiff or also create scar tissue into them. And then based on however the wrist is maybe splinted or cast or what have you, you're not moving your wrist back and forth, so that the tendons that go in from the forearm into the hand can therefore be adaptively shortened. So all of these things need to be addressed when you come into physical therapy. So what is the role of physical therapy? So now that we know how the wrist moves, we know how it's healing, we as physical therapists will take a look when Dr. Mensch deems it appropriate and the fracture is stable enough for us to kind of do our thing. We'll look at what your range of motion looks like, what your strength in that arm looks like. Is it your dominant arm? Is it your non-dominant arm? What are your work duties that you are working to get back to? Are you a carpenter? Do you have to use hand tools that really require that hand to do a lot? Or, are you on the computer all day? So those factors we take into account when we evaluate a new patient with these types of injuries. And then based on what we find, we kind of initiate a plan of care. And within that plan of care can be, if the motion looks great, we might skip over things like joint mobilization and range of motion. If it's lacking in some things, then we'll be working on some of that. Neuromuscular, that should say re-education, sorry, not mobilization. Neuromuscular re-education is about retraining your muscles. They haven't been used in a while since they've been immobilized. So they need to be retrained in how to move and how to bring your wrist and your hand into the motions that need to occur. And then finally, bringing you back up to the strength that you were prior to injury. So using progressive resistive exercises to do so. So what those look like is these are two examples of manual therapy. In the first picture on the left is me doing some wrist mobilizations of the wrist joint, the proximal row of the carpi on the radius. And the second is to work on that the radial head. So we're working on that pronation, supination up there, right? And we're working on restoring those gliding, that rolling, all of those motions, those little finite motions that occur in the joints so that you can restore your normal mobility and function. So this is pretty heavy usually in the first parts of therapy. And then as you improve in your ability, that's when we start to kind of wean out of the manual therapy into the other stuff. Neuromuscular re-education, so doing things like mobilization with movement. So in these pictures, you have the patient is holding a strap down, kind of doing a self-joint mobilization while he's moving into extension. So we're training that joint to glide as it moves into the motion it needs to go. So it can include things like that. It can include isometric exercises, active motions, things that train those muscles. As we gain new range of motions, they need to relearn how to move you into that new motion. So that's what neuromuscular reeducation is all about, is getting those muscles to be retrained to remember how to move you there. And then finally doing various progressive resistive exercises using dumbbells for wrist flexion extension. We use a hammer for pronation, supination, strengthening. We have all kinds of little tools, putties for grip strength because you haven't been gripping too much. But this is usually starts somewhere in the beginning of the process to whatever you can tolerate. And maybe you don't use a dumbbell initially and you progress to a dumbbell as you can tolerate it. And then, and can also be continued well after you're done with physical therapy so that you get your strength back to your normal. So that is kind of generally what I have to speak about. Physical therapy at Ortho NorCal, we have 2 locations. We have one in Capitola on 41st Street and one in San Jose at Westgate Mall. Both locations are very capable of treating all of these types of injuries. And hopefully you don't ever need us for this, but if you do, you know where we're at. And that is all I have.
That's great. Thanks, Charlene. That was very informative. I guess I'll have to ask you to unshare your screen so Dr. Mensch can share his part of presentation.
Absolutely.
Take it away, Dr. Mensch.
Okay, sorry for the delay. I'm just trying to get it up on the screen. There we go. Okay, can anyone see that?
Yes.
Okay, good afternoon, everyone. My name is Kenneth Mensch. I'm the hand and upper extremity specialist here at Ortho NorCal, and I'm honored to be able to speak to everybody over the webinar. It makes it a lot easier, especially during these COVID times. So it's very good to meet everybody. We chose this topic of distal radius fractures, not because we're hoping people get a distal radius fracture, but just to let a common topic that can kind of break the ice for you to get to know not only myself as a hand surgeon and Charlene and her whole team of therapists, which they're very, very good at what they do and they're very close to us. So like location-wise as well as communication-wise. So to kind of introduce myself, here's the agenda I want to go over with you all, looking at distal radius fractures. What are they? So give some examples. When do they occur and who usually sustains these types of injuries and what kind of treatment options you can expect. Charlene did a great job talking about what is recovery, but you can also see how I'll be seeing you periodically after your injury to make sure that you're recovering appropriately too, in conjunction with Charlene and her team. I wanted to discuss expectations of after recovery and kind of how we do it at Ortho NorCal, which kind of sets us different from other physicians in the area. So just to start off, I know I'm new to the area and I'd like to introduce myself to everyone. I trained in the University of Vermont for medical school. I went, you can see the Alamo back there with my family for UT San Antonio for my residency. I was fortunate enough to be asked to go to Zurich, Switzerland with Dr. Gerber to do some shoulder and elbow specialist training there as well. And on the right is a picture of upstate New York, looking at a beautiful waterfall where I trained and did my hand fellowship, which is special because it was not only orthopedic hand surgery, but also plastic hand surgery. So looking at a little bit more complex views of looking at both different ways to look at hand surgery. So I was very fortunate there to do shoulder and elbow and hand at SUNY Upstate New York. Some interests of mine, I put one of my biggest one, the biggest picture there is with my family. That's Pompeii. We both love to travel, even with little children. We're not nervous to take them on a plane long distances. I love to go skiing with my wife and my little girl. You can see up in the upper right corner. And then I also love to go fishing, that's a fish caught off the Texas coast, a black drum. So I really love fishing. So if any of my patients come in and want to chat about fishing, skiing, or traveling, I'm definitely your man to talk to, okay? So let's go on to distal radius fractures. They're commonly just called wrist fractures. When your friends are telling you I had a wrist fracture that was treated in a cast or I had surgery, we were talking about distal radius fractures. I think Charlene did a great job discussing exactly what she's talking about with distal radius fractures. So I'm not going to belabor the point. But looking from an orthopedic standpoint, the most common fracture seen in the emergency department is a distal radius fracture. And they're about 3% of all upper extremity injuries. The incidence is getting more and more every year, but right now it's the census is kind of showing 640,000 of these injuries annually. So our patients are keeping us busy as orthopedic surgeons and hand surgeons. So who sustains these types of injuries? There's kind of two types of patients. There's a one peak in the 5 to 24-year-old range. These are usually male dominant, usually related to athletes that are high energy injuries, such as motor vehicle accidents or playing sports, skateboarding, and so on. The second peak is in our elderly population, and this is predominantly females, and they're usually a lower energy level, and these can be associated with fragility fractures, such as those who have vertebral fractures or hip fractures too. People who have osteoporosis are at a risk of a fragility type distal radius fracture. So talking about fragility fractures, the U.S. Census indicates that we're going to be increasing our elderly population greatly by 2020, or this is actually an old stat, to 50 million. So it keeps increasing every year. And osteoporosis is the leading cause of fracture in these elderly patients. Distal radius fractures, unfortunately, when seen in these types of patients, can be a precursor to other type of fragility fracture or osteoporotic fracture. So these are a type of patients I see a lot in my practice. Some examples of different types of distal radius fractures. On the left of the screen, there's a growth plate open, which you can see that's not a fracture, but that's in a young kid. And you can see where the arrow is pointing, there's a little bit of abnormality in the cortical bone, which is what we call a buccal fracture, which is a very common injury in kids with open growth plates. So these are types of fractures I do treat. In the middle is more of a younger patient in their 20s, high energy. There's a lot of comminution, which means a lot of pieces to the fracture. And you can tell that the cortical bone is very strong. So that's usually a younger patient. To the right, you can also see that in distal radius fracture in an older patient, more of an osteoporotic fracture, and it's not as comminuted as the younger patient, but you can see different fracture patterns amongst these patients. So what are the treatment options? This is kind of a discussion I had with my patient, but you can kind of divide it up into non-operative treatment and operative treatment. So to go over non-operative treatment, like Charlene was showing, is commonly treated in a short arm cast or a brace that can be removed, as you can see on the right. And the advantage of these casts is, we put them on in a certain way. We do this in our clinic. I make sure it's done correctly, and the patients can move their thumb and fingers from the get-go. I want them to have their hand mobility back as soon as possible while we keep the wrist in a safe position. But this cast does stay on for a considerable amount of time, for 6 weeks. Looking at a kind of a case example of a non-operative fracture, discussing with a patient. This is an older patient who is active, however, is not a manual laborer. You can see 3 views of the wrist that show the fracture, and I put an arrow kind of show you what I'm talking about. And you can see this fracture is what I would describe as not displaced, not a lot of comminution, not a lot of fracture fragments, and it's pretty reasonable alignment. And so when I'm talking about alignment, is I'm just looking at these 2 measurements specifically, and it's on the right, you can see it's a neutral position. And on the left, you can see that the inclination, the kind of the curve of the radial styloid of the distal radius is preserved. So if this fracture heals where it is now, I'm happy with that. I think the patient will do well overall. Going on to operative treatments, the operative treatment helps with more of a comminuted fracture where there's a lot of pieces in the background, in the articular surface, and with a plate and screws, you can usually get a better alignment than you can do in a cast, fortunately. And a radial alignment, you get your alignment and your length, so you can restore kinematics, kind of going on to starting the foundation that Charlene is going to work on later, getting your motion back. So you have the foundation to get your motion back. And like I said, you can get your motion back a little bit sooner, and I'll go over this later with operative treatment versus non-operative treatment. The plate and screws provides very good stability to help you keep your length in alignment until the healing has happened. There's some pros and cons to operative treatment, which I'll discuss later in my talk. Things that concern me when I'm looking at x-rays, discussing with my patient their needs and their activity level of loss or reduction, which could be gained in the first reduction of the distal radius and put in a cast. However, there are some signs that I'm worried that it still will lose its reduction after the cast has been placed. Patients with severe osteoporosis is a big concern for me. If you have another fracture associated with the distal radius fracture is also concerning. Like I was showing in the picture, and I'll show you in the next picture, comminution bone on the dorsal or the back of the wrist kind of prevents you from having a good base to keep that fracture aligned and reduced, and kind of looking at your dorsal angulation. So that just means that angle that I was showing you on that non-operative example, and I'll give you an example with an operative example. Initial displacement greater than 1 centimeter and radial shortening greater than 5 millimeters. So this is just simply saying how far the fracture had moved initially during the injury. I can see that on injury films, and also how much the bone has shortened really will tell in the kinematics, especially talking about pronation and supination like Charlene was talking about, as well as flexion and extension of the wrist. So these are signs that I'm looking at that there could be a loss reduction and potentially a poor outcome. So here is an example of an operative patient. You can see here that the image on the right shows that the angulation of the wrist is more to the back than to the front. If you looked previously, and I'm going to go back, this is more of a neutral position of the wrist compared to the operative example. So in the operative example, you can see that the wrist is no longer in neutral, and you actually lost some length on the left side image. So I'd be concerned that the patient would have concerns for motion after this heals, as well as loss of length, which would change the kinematics of this patient's wrist movement. What I would expect to restore it back to looking at the actual reduction of the fracture is what you see on the right. So there's actually quite a bit of shortening of the fracture, as well as a loss of angulation and inclination on the left. So there are some objective findings that I'm looking for in my x-rays, while also discussing treatment options with my patient that kind of steer me towards operative versus non-operative treatment for my patients. So there's an example with that same, that's what it looks like post-op. I put a plate on with screws, and the plate holds that fracture in a better position. And you can see that the inclination is back and the length is back on this distal radius, and as well as your volar angulation. So my goal is, with this held in this place, after the fracture heals, the patient, while working with therapy, will gain back that motion. So kind of going over pros and cons, and this is a conversation I have with my patients. No one has to have surgery. No one has to not have surgery. We kind of talk about pros and cons. And when looking at non-operative management, especially in a cast, the pro is you don't have surgery. So you don't have the risk of surgery involved and the risk of anesthesia. And you can have a good result like that first example. If that fracture stays in that position, I think the patient will be very happy. However, there are cons. There is a chance of loss reduction. And I went over those objective findings I look at to kind of help guide our decision making. And you do have to come back the first 3 weeks after the injury to make sure that the fracture hasn't moved while in the cast. The cast can be cumbersome. It makes it difficult for hygiene, and cast care, keeping it clean, keeping it intact, can be very difficult for some patients. And there's also delays the time I can go and you can go see Charlene. Usually at the 6-week mark after the cast is removed is when you can start working on your range of motion activities. There's also risk of tendon rupture and a possible delay in surgery. So for example, if we think, okay, let's try to do non-op and see how the fracture looks in a week or two. If the fracture loses its reduction, then we might have to, force our hand on doing surgery at that point. So it could be a 2-week delay on the healing process. Operative management with surgery, like the example I gave you with plate and screws, it's a better maintenance of reduction. There's no cast. I put you in a post-operative splint right after. So it's a softer splint, not as heavy, easier for your self-care, and hygiene is easier. But there are cons. There's risk of surgery. There's a different type of tendon that could be ruptured. And there's possible future surgery, meaning the plate needs to be removed later on if it's bothersome to my patient, or if there is a tendon rupture that would have to be fixed as well. So what does recovery look like? This is something that goes back for each patient. So it's not set in stone, but non-operative, I like to keep my patients in a cast for 6 weeks. The first 3 weeks, we have a weekly visit just to make sure the fracture has stayed in an appropriate position. At the 6-week mark, I like to transition you all to a removable splint. And at 6 weeks, we begin some therapy. But at 8 weeks, we can start discontinuing the brace. This might be pushed off for 2 more weeks if it's some fracture that I'm concerned it's not healing as fast as I originally had hoped. But this is kind of a general time frame. For my operative patients, we put them in a post-op volar splint, which is more of a small splint that just goes down to a little bit down the wrist, keeps the wrist in a safe position. The soft splint that's lighter, so patients usually like it a little bit more. At the 2-week post-op, we take out sutures, we take you out of the splint, and we give you a nice, comfortable removable splint that you can take off for hygiene, showers, washing your hands. And at 6 weeks, we begin to do therapy, and we can start weaning out of the brace shortly after. So my expectations for my patients after recovery, we're hoping for minimal pain with motion. You did have an injury, and the injury doesn't just affect the bones, but also affects the soft tissues. And that's what Charlene was talking about with scarring. So early on, you've been immobilized in either scenario, operative or non-operative. So early on, you'll have some stiffness in the wrist. So that's where we work with therapy to get that motion back in a timely manner, but also to let the bone heal. And with surgery, you do have a surgery scar that can be tender and as it heals. So this happens, and our therapist can also work on some scar desensitization as well, which will help with that. Kind of talking about care at Ortho North Cal, we're a network of orthopedists. So I'm the hand and upper extremity specialist, but we also have specialists of foot and ankle, total joints, spine. And so once you get connected with me or one of my colleagues, you definitely can still be referred within the practice to people who know each other and can kind of keep each other up to speed on our patients, which is very nice. I like to call us a one-stop shop. Everything is on site, which makes it convenient for our patient. We have X-ray on site, so I can send you to X-ray during your visit. MRI is on site, and therapy is on site. We even have a local cardiologist come in once a week to help with preoperative clearances to make it simpler for our patients so that they can get their surgeries and care in a timely manner. I think the biggest thing by talking about us all being in one stop is the communication between all of us. Charlene and her therapist have my number. The therapists over in San Jose have my number. X-ray techs, MRI techs have my number so that we can all discuss what's best for this patient and the game plan for their treatment. Our radiologists also know my number, so if they're kind of wondering what is the study for, what am I looking for, we can have that conversation. It's not just through email and through EMR, through electronic medical records. And we also have convenient surgery centers, which are very close by. Just as our therapists are close, our surgery centers are within the minutes of a drive from our site. So I feel like that kind of keeping everything within the one institution really helps provide appropriate care for our patients, convenient care, and evidence-based medicine. So I want to open this up for questions. I know I talked a lot. I know I gave a lot of information. This talk was to kind of introduce Charlene and myself to our patient population, but it's not just the only thing that we treat. It's just an example. So if you have any other questions, please feel free to ask us. I specialize in fingertip all the way to shoulder injuries. So I do shoulder replacements and cuff repair, as well as fracture work amongst the wrist, elbow, and shoulder.
Thank you, Dr. Mensch and Charlene. We do have a couple of questions to start with. How do you assess a distal radius fracture?
How do I assess it? Usually patients come to me after being seen in the emergency room, which the doctor have my number if they need to ask some questions, usually in the splint. I kind of introduce myself to the patient to kind of see like where are they at with, how active they are with their hands. Do they do a lot of hobbies with their hands? You know, do they do a lot of labor with their hands, and kind of get an idea of their lifestyle. And then we go and look at X-rays together, and kind of discuss the surgical or non-surgical options for my patients. So that's how I assess the patient after a distal radius fracture. I do take off the splint and assess the skin to make sure everything is intact, everything looks good. But that's how I assess it.
And Charlene, do you have an addition to that?
As far as assessing if they have a fracture, that's not my job, but we would assess after they're cleared by Dr. Mensch to come to us to, you know, again, look at their motion and then try and get the patients back to the function that they've were doing prior to the injury.
Thank you both. The next question, how long does it take to get a full range of motion after broken wrist?
That can vary depending, I would say, on the severity of the injury and sometimes even surgical versus non-surgical. Generally, it can take a good, you know, up to 8 weeks or so after they've been in therapy to get full range of motion. That's not saying they're not gaining motion throughout that time. But to get to that full range of motion and function, probably somewhere between 6 and 8 weeks following their initial evaluation, somewhere in that time frame.
I agree with Charlene. The first 8 weeks is where they really gain their motion back. It's when you start working the scar and the scar begins to mature. But I encourage my patients to continue doing the therapy even after they see Charlene, because it can be up to a full year where you start really getting a lot more motion and strength. So there's not just, I wouldn't stop at the 8 week mark, but yes, I think most of the motion comes back in that first couple months.
Thank you. The next question, can you break your radius and not know it? How often do you see such fracture?
That actually is possible. I've had several patients present what I call a delayed fashion, where they thought they had a sprain and it just wasn't getting better. And usually it's within 3 weeks to 4 weeks that they come and see me, but it's not uncommon for it sometimes to happen where patients come back, especially if they're in a care facility, where it might take, you know, a few months, but normally patients come and see me within the first week.
Thank you, Dr. Mensch. At what point I know I will need a surgery? How many physical therapy visits after I realize it's not working out and I need a surgery?
So if we're talking about non-operative versus operative, like if I put you in a cast for a week, I see you back in the following week, and if the fracture has moved into an inappropriate alignment where I'm concerned that you might have a poor outcome, we would get started then with scheduling you for surgery. With regards to therapy, usually the decision's made before you get to therapy. So I don't think that you go to therapy at 6 or 8 weeks and you're unhappy with it. It's usually we made that decision when we see the fracture. We try to be proactive and see the fracture alignment and see that if we lost that alignment, we should be proactive when it's a simpler surgery than having to do a more complex surgery a few months down the road.
I also think that, I don't know if the question is more also geared towards removal of hardware, if that's potentially what the question is. So if the hardware seems to be limiting the mobility or creating more pain in the patient, then we would definitely have Dr. Mensch continue to address it. But you know, he can answer this better, but my understanding is the hardware probably needs to stay in for a bit of time to make sure that fracture is fully healed before they'll even talk about removing it, if that's where the question is more geared towards.
Yes, probably. Thank you, Charlene. Is there anything that can be done after 2 years of the surgery, or do you have to live with the limitations and pain?
I think that depends on what's causing the limitations. If for some reason, you know, you're one of the patients that broke their wrist and didn't realize it had broken and it healed where it was, you know, there are surgeries we can do to realign the distal radius that can help. So yeah, there are surgeries after the fact, but they're more challenging. But you know, those are surgeries I can do as well. I just like to do it sooner than we get to that point, but that doesn't mean we don't have options later on.
And then I would just add that if they've been into therapy post-surgery or post-injury, or even more recently, now that you're 2 years out, and see if there's something initially we can conservatively try to do before we jump into surgery. And then also back to is it a hardware issue, and is it just I don't want to say simple removal of hardware. It's not, that's never a simple thing, but if the hardware is removed, will that maybe improve the pain and the motion that the patient has at the wrist?
Thank you, Charlene. Next question. Do you also perform wrist replacement surgery? What are the indications for that procedure?
At this point, I'm not doing wrist replacement surgery. I was in my fellowship, we were testing wrist replacements. And right now I want to see the data and make sure that, you know, the results are safe and effective for my patients. So I think we're moving on the right direction for wrist replacements, but at this point, I'm not doing wrist replacements. I do offer either limited fusions, which will fuse just you know, with that picture that Charlene was showing with the multiple carpal bones, just fusing the ones that are arthritic versus a full wrist fusion for pain. But I'm not offering a wrist fusion, a wrist replacement yet.
Thank you, Dr. Mensch. And since you are new in the area, patients wants to know what hospitals you're affiliated with.
Oh, that's a great question. I should have put that on my slide. So I'm in 2 locations, or 3 locations. I'm in Los Gatos, and I'm affiliated with Good Samaritan in Los Gatos right now. And then on the Santa Cruz and Capitola side, I'm at Dominican Hospital. And I also do have a satellite clinic in Watsonville where I see patients too.
Sounds great. Thank you so much. I think that's all for the questions. Thank you both, Charlene and Dr. Mensch. And thanks everyone for joining us today. As I mentioned earlier, the webinar recording will be available on our website within 24 hours. Please email us if you have any additional questions at info@orthonorcal.com or call the office at 408-412-8100. Thank you and enjoy your afternoon.
Thank you, everybody.
Thank you.